Okay, let's go ahead and get started. Thanks for joining us for Medical Grand Rounds. I'm David Schwartz, Chair of Medicine. This presentation will be recorded for future reference. You'll be muted when you enter the meeting, and at the bottom of your screen, there's a Q&A icon. Use this icon rather than the chat feature to submit your questions. Submit as many questions as you want during the presentation. There will be ample time for discussion in the latter part of the presentation. I'll moderate this question-answer period, and it'll be a discussion that is based on the questions that you put into the Q&A box. COVID-19 is different than other viral pneumonias. While most viral pneumonias are confined to the lung epithelium, SARS-CoV-2 attacks the epithelium and also the endothelium, both causing airspace disease as well as an endothelialitis. This results in inflammation of the vasculature, hypoxemia out of proportion to the pneumonia, and in rare cases, thromboses. Today, we have 4 outstanding speakers with expertise in this area. The lineup includes Dr. Eric Schmidt, who will discuss the role of endothelium in ARDS and its effect on the vasculature in the brain. Dr. Kurt Stenmark, who will demonstrate the unique effects of SARS-CoV-2 on the endothelium, distinguishing it from other forms of ARDS, and considering the potential role of complement in mediating this process. Dr. Todd M will show the unique clinical manifestations of SARS-CoV-2-induced ARDS, with examples including the D-dimer story, ventilation perfusion matching, and thromboembolic disease. And Dr. Kathy Hassell will discuss the role of thrombosis and anticoagulation in this disease. Okay, let's get started with Dr. Schmidt.
All right, well, thank you very much. My name is Eric Schmidt. I'm a physician scientist. I see patients at Denver Health, but I have a laboratory here at the university. And I'm going to kick things off by actually not talking about COVID-19 per se, but talking about ARDS in general and the critical role played by the pulmonary endothelium in ARDS, not only in the lung injury that's characteristic of ARDS, but also in the multi-system organ failure that plagues patients who have this critical illness. Now, with regards to this, I have no conflicts to disclose. Now, it's good to start with just a description to remind everybody what ARDS is, and we often refer to this colloquially as lung injury. So this is the acute onset of severe hypoxemia, and it's got to occur in response to some sort of insult, either an environmental inhaled direct injury to the lung, or some sort of systemic illness that hits the lung, presumably via the vasculature. Now, it leads to severe hypoxemia via the induction of a neutrophilic alveolitis that causes a non-cardiogenic pulmonary edema, and that leads to the shunt physiology that's characteristic of this disease. Furthermore, there's known microvascular thrombosis in ARDS, and this causes dead space formation. These things all translate into a substantial mortality and morbidity of this disease, as recently quantified in the Lung Safe study published in 2016. Now, whenever anybody talks about ARDS pathophysiology, they're obliged to show this slide. It's 20 years old, but it's still, it's from Lorraine Ware and Michael Mathey, a review in the New England Journal, but it still nicely captures the relatively organized appearance of the normal alveolus with a structure that allows atmospheric gases to interface with the blood across this very thin alveolar membrane. Now, during ARDS, you get activation of inflammation. This causes endothelial leak, which causes widening and flooding of the interstitium, leading to epithelial injury and epithelial death, causing flooding of the alveolus. Now, atmospheric gases can't reach the vasculature, leading to this shunt physiology. Now, you notice the way I explain that, I defaulted to this. I defaulted to a linear pathway, as scientists are apt to do. I said that there is activation of immunity that damages the endothelium, that damages the epithelium, that leads to ARDS. And the fact of the matter is that's just not that simple. If only it were that simple. If it were that simple, I could block neutrophils, or I could block endothelial dysfunction, and I could prevent ARDS. In actuality, it's much more complicated. During ARDS, there's this complex, chaotic microenvironment where cells are interacting with each other across multiple pathways, some protective, some harmful. So you can't just say that endothelial cells are the cause of ARDS. They may be trying to help the host as well. Now, that being said, the endothelium is quite important to a couple of key facets of lung injury. And for sake of time, I'm only going to talk about two of them within the lung. That's the role of the endothelium in neutrophils damaging and inflaming the alveolus. And furthermore, the role of the endothelium in driving microvascular thrombosis. Now, to understand the neutrophilic alveolitis of the ARDS, we first need to recognize how neutrophils get out of vessels in other organs, non-pulmonary organs. This has been studied for decades. And in other organs, neutrophils squeeze out of vessels in the post-capillary venules. It requires this highly patterned process in which there's rolling, and then these endothelial cells adhere, and they crawl, and they find a gap either in between cells, or there's increasing recognition that can actually go through endothelial cells. But again, it requires this rolling process, and it occurs in the post-capillary venule. The lungs, however, are fundamentally different. Neutrophils don't go out in the post-capillary venules, they go out in the alveolus itself, in the capillary itself. And it doesn't require rolling at all. The reason is that the lung microvessels are thought to be a little bit smaller, and the neutrophil's got to squish its way through, and this pauses the neutrophil transit. It used to be thought it paused it for a while, although recent data suggests it's only a transient slowing. But it doesn't get stuck, in part because the neutrophil is flexible, but also because the endothelial cells are quiet. They keep their adhesion molecules within these Weibel-Palade bodies inside the endothelium. The entire endothelium is covered by this sugar layer called the glycocalyx, which our laboratory has studied for over a decade. But during ARDS, things get activated. Neutrophils get stiff and they get stuck in the vessel. Furthermore, the endothelial cells get angry. They start to express these adhesion molecules, and this glycocalyx, this protective endothelial surface layer, which obscures these adhesion molecules, is degraded, leading to a showering of pro-inflammatory fragments, exposure of adhesion molecules, and actually a change in the endothelial phenotype, so it becomes more pro-adhesive. This leads to neutrophils sticking and damaging the alveolar capillaries, and leading to an alveolar inflammation, a neutrophilic alveolitis. What about thrombosis? Well, obviously endothelial cells have got to be anticoagulant, otherwise we'd be clotting all over the place. And this is governed, this anticoagulant nature is also largely governed by this endothelial surface layer, which harbors a number of anticoagulant proteins. Tissue factor pathway inhibitor exists within the glycocalyx. Heparan sulfate binds to antithrombin 3, which negates thrombin. Furthermore, thrombomodulin, which is a proteoglycan, which is part of the glycocalyx also, leads to the activation of protein C, another anticoagulant. Furthermore, the endothelial cell itself produces antiplatelet factors, such as nitric oxide, which inhibits platelet aggregation. Now, during lung injury, the endothelial cell is damaged, and in models of infectious lung injury, like influenza has been shown, there's a group at a University of Toronto, Warren Lee's group, who's shown that you can actually get direct endothelial infection, and this drives thrombosis. It leads to platelet aggregation and clotting of microvessels. And also there's a significant increase in alveolar clotting, as shown here by fibronectin and fiber deposition. Furthermore, endothelial cells stop making nitric oxide. They make superoxide instead, increasing the activity of platelets. So these are just two of many examples of how blood vessels can drive the local lung injury. But anyone who's taking care of ARDS patients knows that patients with ARDS don't only have lung injury. They have multi-system problems. And survivors of ARDS often face persistent cognitive impairment. This is seminal work done by Dr. Hopkins at University of Utah. And she observed that ARDS survivors, while they may regain their intelligence as measured by intelligence quotients, they have persistent problems in memory formation. And what's incredible about this is the pulmonary endothelium may be the culprit, at least in part, for these memory problems in the brain. This is work that's pioneered actually by one of our own, Joe Hippensteel, who's an instructor in our division. who really did incredible work looking at how sepsis, a major cause of ARDS, can damage the endothelial glycocalyx, showering fragments of this sugar called heparan sulfate into the blood. And strikingly, they only penetrate the part of the brain that's responsible for spatial memory formation, the hippocampus. They gobble up a key growth factor, BDNF, that prevents memory formation, leading to the septic cognitive dysfunction characteristic of patients who survive this critical illness. And this is clinically relevant. This is work done in collaboration with a group at the University of Pennsylvania. These are patients who showed up with sepsis. And in the ER, we measured their blood. We measured heparan sulfate fragments, these glycocalyx fragments that are specifically bind BDNF, that growth factor necessary for learning. And then weeks later, 14 days after ICU discharge, so weeks later, we measured cognition and found that patients with the highest amount of these specific fragments that specifically bind BDNF, those patients had a dramatically increased risk of persistent cognitive impairment characterized by memory deficits. Now, we're not the only ones that show this. Interestingly, a group at the University of South Alabama, Troy Stevens, showed something quite similar. Their group took endothelial cells, lung endothelial cells, in vitro and infected them with Pseudomonas. And these endothelial cells produce prions, prion-like proteins, tau and A-beta amyloids, which actually, if you do a bronchoalveolar lavage on a patient who actually has a ventriculoperitoneal shunt, which I'll explain in a little bit why, they took these patients who had VP shunts who had pneumonias, and they did BALs on these patients, and they had a lot of these amyloids, these prion-like amyloids in their BAL, and they took the CSF from this VP shunt and isolated these amyloids. If you took those amyloids from the CSF of pneumonia patients and gave them to mice, that by itself was sufficient to cause cognitive impairment. Again, an endothelial produced product got into the brain and causes cognitive impairment. So with that, I like to end. I just want to remind people that we know the endothelium is important to ARDS. It's important to the lung injury characteristic of ARDS, and it's important to the multi-system consequences that really contribute to the morbidity of this critical illness. And with that, I'd like to end. I'm going to pass this to my colleague, Dr. Stenmark.
Thank you very much, Eric. I appreciate the introduction. You are screen sharing. Now I just have to find my... there it is. Can somehow we go back to the beginning? I want to just state that I am speaking today on behalf of not myself, but a team of investigators that were assembled to look at the role of complement in pulmonary hypertension in a program project grant. And so these include Maria Frid, Ruben Tudor, Josh Thurman, Michael Holers, Raul Torres, among others, who have allowed us to pivot and transition, from our interest in chronic forms of pulmonary hypertension to the acute pulmonary vascular injury that Dr. Schmidt has just described. And so we think that endothelial cells are essential in the initiation and propagation of severe COVID-19. And we think that in addition to the epithelial cells that generate the initial problems, that the endothelial cells are infected or else affected by the SARS-CoV to produce this vascular leakage that Eric described, to become coagulopathic, and to stimulate and cooperate in the generation of severe inflammation. So just as an example, a New England Journal paper recently showed that perhaps not unique, but in some ways unique, there's this very distinct capillaritis that happens, endothelialitis, characterized by a very significant lymphocytic inflammation. And then more importantly, shown on the right-hand side in the arrows, are microthrombi in the intraalveolar septa. So this is perhaps not distinct, but very prominent in cases of COVID-19 ARDS. And so again, just showing the endothelialitis again, at higher magnification, these small blood vessels become filled with both neutrophils and mononuclear cells that Eric described. But in addition to that, these investigators demonstrated that activated caspase-3, which is a marker of apoptosis, was very prominent in this disease process. And so now we are having cells that are not only affected, but are actually dying during this process. We also see in this electron micrographic representation that there's a massive architectural disruption and distortion of particularly the distal capillary bed that some people are speculating is very distinct. And as our friend Dr. Fauci would say, this virus continues to amaze us with all the new and distinct things it seems to be capable of that differentiate it from other viral infections. And so given those changes in the endothelium, in coagulation, and in inflammation, we wondered what could possibly be integrating such a massive change. And so similar to our studies in pulmonary hypertension, we hypothesized that activation of complement could be involved. And we know that complement is highly beneficial for viral clearance. And so there is no doubt that complement in the right spaces and at the right time will be essential for COVID-19 resolution. But under other circumstances, the complement system, as well demonstrated by Dr. Hollers and Dr. Thurman, can turn destructive. And then when you have local tissue complement activation, be it through any of the 3 classical and maybe 4 classical pathways, lectin pathway, which will be directed at the virus itself, the classical pathway, and the alternative pathway, they will have downstream effects that can mediate inflammation through products such as the anaphylatoxins C5a, C3a. Those same products are highly important in platelet activation and ultimately aggregation. Vascular permeability and leakage can also be mediated by C5a, and host cell responses such as inflammatory activation, ultimately damage, and probably even the apoptosis can be mediated through activation of the terminal pathway. Sorry. So we took some time to look through the literature that's available at the present time, and it's been very well established that all of those pathways that I just mentioned in complement are present within the lung capillaries of patients who have died of COVID-19. So this includes MASP2, which is indicative of activation of the lectin pathway, C4D, and so these are active fragments. So that's important to note that this isn't just seepage of serum complement into the lung, but actual activation of those pathways in the lung vasculature itself. C4D, the classical pathway, C3D, the alternative pathway, and C5B through 9, the terminal pathway. So all of those pathways that I mentioned, there's evidence are being activated in this disease process. It should be noted that this activation is taking place largely in areas that can be co-localized with the SARS-CoV-2 infection. But other places, it looks like there's activation in the absence of specific SARS-CoV-2 activation. So now we get transitioned into trying to understand exactly what's going on. And as I said, these complement fragments are playing a crucial role in recruiting inflammatory cells, in coagulation, platelet activation, increases in tissue factor, increases in von Willebrand factor, P-selectin. And the same thing is true for members of the lectin pathway. So the mannose-associated secretory proteins, proteases, are very prominent in activating complement activity downstream, as well as having extreme procoagulant capabilities. So as an interim summary, we would suggest that many people have left it at this, that SARS-CoV-2 infection can drive endothelial injury through direct infectious processes, which lead to activation of various components of complement, which then in turn cause further endothelial injury, but they also cause platelet activation and thrombosis. So we were intrigued, though, by the descriptions that had been made in the clinical arena and what Eric just described, and that is that these diseases characterized by unusual and severe hypoxia. And so one of the recent papers demonstrated that, in fact, COVID-19 has features that may be very distinct from other forms of ARDS caused by other viruses. And in particular, we were interested in the transcriptomic analysis that revealed dramatic upregulation of many factors, many of which are associated with severe hypoxia. So the studies that we had been doing in conjunction with Kirk Hansen, we were carrying out some of the very first complete proteomic studies of the lung vasculature under hypoxic conditions. And so we were able to evaluate over 1,600 proteins. And interestingly enough, in yellow, you'll see that the proteins that we see with hypoxia alone overlap nicely with many of the gene products that were identified by these investigators in the New England Journal paper, and are distinctly different than those in the other disease processes. So this led to our hypothesis that actually it's possible that hypoxia is enhancing or augmenting COVID infection to drive the excessive disease process that we see, and that the localized EC infection through the effects of hypoxia can have widespread paracrine effects on the pulmonary vasculature. So we've demonstrated previously that hypoxia alone can actually induce many of the same factors that have been associated with the activation syndrome observed in COVID-19, including CSF2, VCAM1, ICAM, that could do these things. And so we went on to say, you know, let's just take a hypoxic model and see whether or not complement gets activated and whether it could be by itself causing some of these problems. So in a paper that we recently published, Dr. Frid is the first author, we showed that hypoxia alone can induce the expression of neoepitopes or neoantigens on the endothelial surface that are recognized by circulating immunoglobulins, probably both IgM and IgG, which then activate complement. And that activation of complement in this local tissue environment within the small blood vessels of the lung then induces, in a complement-dependent fashion, cytokines and chemokines, including CSF2, CCL2, which induce recruitment and activation of macrophages, resulting in the inflammation and remodeling. If we knock out various forms of complement, we can abrogate really the whole process. So we became interested in this, and we were working with a company that had made specific inhibitors of hypoxic inducible factors and HIF1 and HIF2. And so interestingly enough, we found that under hypoxic conditions, HIF2 is activated, and that the HIF2 is associated with complement deposition. But when we completely abrogate the HIF2 signaling alone, we can get rid of all the complement shown on the right-hand panel. So this made us really think carefully about this enhancement in interactions between the COVID virus and the others. And we actually went on to show that potentially some of the disease process could be ameliorated by simply targeting HIF2. Shown in this, we can see that if we block HIF2, we can block monocyte recruitment, we can block proliferation, and we can block the remodeling process as assessed by early collagen markers and deposition. So this really leads us to conclude at the current time that SARS-CoV-2 does have very important and damaging effects, but that its side effects and the association with hypoxia actually, we believe, drive the severity of the disease in a way in which we can think of ways to potentially ameliorate the disease process. And so as people may know, that there are several early clinical trials demonstrating that blockade of C5 is, at least in some patients so far, has been beneficial. A new investigator who we're working with has an inhibitor of, I don't know what just happened, but of the C1. And so we think that it's possible that inhibiting complement in the right way at the right time, potentially even in the presence of blocking hypoxic inducible factor expression, may allow us to ameliorate the disease process. So thank you very much. Todd? Did I stop the share correctly?
Yep, you're good. All right. Thanks, Kurt. I'm seeing my slides here. Okay. I want to thank Dr. Schwartz for the invitation to speak here today and to join my esteemed colleagues in what I consider one of the most fascinating aspects of this pandemic as it's rolled down, and that's its implications towards the pulmonary vascular bed. I'm a little biased in that assessment, I'm sure, but share that bias with many on the of my panel here today. So here's jumping into my disclosure, just to put out that I am a co-I on this study looking at fibrolytic therapy for severe ARDS and COVID-19, the STARS study, of which Dr. Moore at Denver Health is the PI, or the main PI here as well. So I think Dr. Schwartz led off this grand rounds with the statement that SARS-CoV-2 appears to be something new and different. Now, certainly a new virus, we wouldn't debate that. It's wreaked havoc across the world from that standpoint. But I think the point for this conversation today is it doing something new and different in a clinical sense? Is it a different form of ARDS, or ARDS, if you will, is complicated by other aspects of the virus? And my bias in this direction, to put it out there, is that is in fact the case. This is formed by my clinical observations, and of course observations across the globe, in which people have been pondering, is this something new? Do we need to approach it in a different fashion? And we'll say up front, and I think many are aware because we've been listening to these grand rounds for a while on these topics, is that we lack really high-level evidence from this standpoint. But we have our observations, and this is really how medicine works, right? Is that we as clinicians observe, we apply the evidence as we know it, and then we look to see, are we seeing something, there's something different. We try to gather that information in first low quality evidence retrospective data, and then we turn to investigation. And so we're hearing, heard it before me, Kurt's sort of thoughts and approach to try to tease this out. And we have a myriad of clinical trials rolling down the road that I think will help us sort this out. So SARS-CoV-2, something new and different. My bias is from the pulmonary vascular standpoint, yes. What evidence do we have of this? We have this evidence that first kind of shot around the world, the concept of a D-dimer problem, meaning an excessive amount of D-dimer being released, and that this is perhaps predictive of outcomes and maybe a surrogate or a biomarker that we should be intervening on. The VTE prevalence, so the clot prevalence, again, many observations that would suggest, low quality evidence, retrospective data, but would suggest that we are seeing a higher prevalence, incidence and prevalence of clotting. Along that clotting standpoint, CVA prevalence, I'm not going to dip into that today, but certainly this is of great concern. Young patients presenting with stroke, case reports from that standpoint. And then from my perspective, again, really what Kurt has now been trying to tease out is this pulmonary microvasculopathy. This to me was really sort of, when the reports started firing out, really caught my attention. And then I would say that I have some clinical observations personally that others have made as well that support that there is something amiss with the pulmonary vascular bed here, and maybe something we need to be thinking about somewhat differently. So let's run through this evidence as it stands. So observational data, retrospective. This was the first reports coming out of the Wuhan province. The study by Zhao et al. Published in Lancet in January. 191 patients. They looked at D-dimer, looked at a variety of markers of outcome, but D-dimer of greater than 1 mic per mil, which is about twofold normal for our sense here. It's had an odds ratio of 18.4 for mortality. So this huge potential marker, at least associated with a mortality benefit. We saw a similar report following that. Zhang et al., also after Wuhan province, 343 patients, they timed to generate a ROC curve for a D-dimer greater than 2 micrograms per mil, 92% sensitivity, 83% specificity, again, for mortality. Now, of course, we all recognize D-dimer is a non-specific marker of a variety of disease states. Inflammation certainly is a breakdown product for fibrinolysis. But this is sort of an interesting look. Dr. Schmidt and I actually were involved in a debate on whether we should anticoagulate these folks about a month ago. And he pulled this slide out on me. And I've learned anything from debates is that if you're getting beat up on debate, immediately switch sides and grab the person's slide who gave it to you. So Dr. Schmidt gave me this slide. I thought it was a great one. So this looks at two of our bigger critical care studies, which were the PROW study and the SCARLET study. These were studies of sepsis-induced coagulopathy. So not exactly our ARDS cohort, though certainly at risk for ARDS, but sepsis-induced coagulopathy, and looked at the D-dimer levels in these two studies. And then if we compare those to the Wuhan data, we see in those two studies that actually our D-dimer levels weren't all that different. Then a couple of follow-up studies, one from New York, another from Wuhan, show that maybe D-dimer wasn't all that high in all of these patients. Anyway, raises some question as to whether D-dimer should be our surrogate marker in terms of intervention. And I'll mention that the PROWS and the SCARLET study, again, were sepsis-induced coagulopathy studies. So they were trying to intervene on this coagulopathy with activated protein C or thrombomodulin without positive outcome, at least in the sort of the follow-up data for the activated protein C for this and for thrombomodulin. So what about VTE though? This to me, I think becomes somewhat more compelling. The presence and incidence of VTE. And so if we look just, for example, in critically ill patients, looking at the numbers here, again, retrospective data, here's able to pull 8 studies. And essentially we're seeing somewhat variable, a pretty high incidence, assuming prevalence of VTE. And these are both DVTs and PEs. Dr. Hippensteel, whose face popped up a little bit earlier on the glycocalyx study, actually looked at our data here at the University of Colorado. I'll dig into that. 27%. If we look at these in aggregate, these again, critically ill patients, so patients in our ICU, 18.6% across all these studies. And this would, if we look back to historical data, H1N1, other disease states, is about 2-fold higher than we would anticipate for VTE in this critically ill population. So it seems, I think most would agree who are looking at this, that these patients have a propensity to make clots. Now I mentioned Dr. Hippensteel, Dr. Jolly, Dr. Burnham actually put this data together and just had it accepted for publication. Looking at our patients, there was a 26.1% incidence of VTE. DVT made up 79% of this data, 21% were PE. Interestingly, there were associations with longer ventilator time if you had a VTE, longer hospitalization time, but no mortality difference, though kind of the unadjusted mortality was pretty close, but almost a benefit towards the patients that had clot, which was a little odd. But again, take this data for what it's worth. Keep in mind that we are not screening for VTE, so these are clinically indicated studies that were done. Likely the prevalence is much higher if we went to a screening evaluation for this. So then let's turn back to sort of my favorite area, if you will, which is the pulmonary vasculature and its clinical impact. And Dr. Schmidt was leading toward this, but I think it's very important to keep in mind how elegant this system is, how smart the pulmonary vascular is. The lungs are smart. They're not dumb like the kidneys. They don't get fooled all the time. They know, your body knows that when you have a big dense pneumonia, that you would just assume not send blood to this region of the lung. You want to downregulate vasodilators. You want to upregulate vasoconstrictors. You want to send the blood to the parts of the lung that are working. So you VQ match. A very elegant system, happens almost immediately through HIF signaling. And then the paracrine and endocrine effects of the endothelium are critical to this. When this falls apart, we end up with hypoxia, and that can be either from dead space ventilation, so ventilating an area that's not perfused, or shunt perfusing an area that's not ventilated. So if you start sending blood to this region, you will develop a physiologic shunt. And so the question then becomes, was what is happening in COVID? And we've already sort of heard that this does happen in ARDS, but this was sort of a myriad of reports, YouTube videos, emails flying around the world saying that, hey, COVID-19 is doing something different here. And this was published by Gattinoni. This was unedited proof. He's published in a variety of formats kind of talking about the same thing. He describes these two phenotypes of ARDS, the L phenotype, which is low lung water, low weight, high compliance. So these are lungs without a lot of non-cardiogenic pulmonary edema in them. They're not that stiff. And then this H phenotype, so more typical of what we think of ARDS, high lung water, high weight, low compliance, very stiff lungs. And I don't know that I buy into these two phenotypes per se. Dr. Gattinoni had talked about these in other before COVID-19. But what I found interesting was the marked hypoxia that was being described in patients that are in this L phenotype. That is not that much going on. Infiltrate-wise, their lungs are still compliant, but they were very hypoxic. And the descriptions of this, I think many of us taking care of these patients have seen this, the patient's talking on the cell phone right up until the time you have to intubate them. You have to take the phone away from them so you can put them on the ventilator. So they don't sense their hypoxia, if you will. Their hypoxia seems out of proportion. And this, being a clinician who deals with pulmonary vascular disease, is very reminiscent of shunt physiology. The patients we see with big ASDs and VSDs, they frequently don't note their hypoxia. And so this really sort of caught our eye. And then we went across the world, we're doing this all wrong. This is HAPE, maybe high altitude pulmonary edema. It's not ARDS. Completely disagree with that statement. But what I did think interesting is this HAPE-like, and that what happens in HAPE, not exactly here, but are we losing regulation of the pulmonary vascular bed? Are we losing the ability to VQ match? And is that why we're getting so hypoxic early on? A hypothesis, not yet proven here at this point. And Gattinoni went on to sort of show in a different publication that he looked at like 8 patients and showed that the shunt fraction here in red was all over the place from this patient group. So the question becomes why. Kurt already went in this, so I'm not going to spend a lot of time on it because I'm going to give my esteemed colleague, Dr. Hassell, time to tell us what to do. But mentioned, could this microthrombosis that was published in this New England Journal paper, 9-fold increase in microthrombi in COVID-19 patients as compared to H1N1 patients as historical controls when they looked at this, and compared to lung donors donates. This was small numbers. These were 7 patients total in each group, but a 9-fold increase in this microthrombi. And then this really kind of caught my eye, a 2-fold increase in angiogenesis. If we look down here in this corner, this is this concept of intussusceptive angiogenesis. So sort of a rapid response of developing new vessels by dividing old vessels. Could this shunt-like physiology relate to this? Is this something different, 2-fold compared to the H1N1 story? And then they describe again virus in the endothelium. So is this virus doing this? There are other hypotheses, that it binds through the ACE2 receptor. Could that be changing our ability to autoregulate VQ matching? There's a lot of different ways this could be thought of, but this would be one potential hypothesis and an interesting one. And is, going back to Kurt's point, if this hypoxia is so important in the development of it, what about this early hypoxic outcome? Is this, driving disease in some way? Should we be more aggressive about trying to intervene on that portion of it? And so lastly, we come to treatment. All right, so Dr. Hassell has the difficult job of telling us what to do. Should we be anticoagulating these patients? Is low molecular weight heparin at higher doses the way to go? What about TPA? If there's a clot, that'll remove it. Here at this point, is that the approach to avoid sort of an end stage disease or to prove oxygenation? And this is, again, we have these observations. Now the studies need to ensue. I think what Dr. Hassell is really going to tell us about is the most important intervention, perhaps, which is a very powerful light. That if we could, get out more. And it's now summertime in the Rockies, so I'm personally looking forward to using this intervention myself, hopefully in the near future. But with that, I will hand this off. My phone is blowing up over comments about the kidneys being dumb. I retract that statement. The kidneys are awesome. Yeah, they're paired organs, so the nephrologist and the pulmonologist need to stick together. All pair organ people need to stick together. So, Dr. Hassell, I will hand this off to you. Kathy, I think you're muted.
Thanks for the reminder. And let me clean up my screen. All right, so in the last bit of time that we have here, I'm going to blow through a large assignment that I can't really fulfill, but to discuss the role of anticoagulation in COVID-19. And there's two aspects I'm going to address. Firstly, you've just heard very elegant conversation about hypoxia, inflammation, complement activation, mismatching. I must say there's no greater way to aggravate the thrombotic and hemostatic system than to invoke all of these very profound effects that a COVID-19 appears to induce. And if thrombosis plays a significant role in either sustaining or feeding back and augmenting these processes, then we should see some information about anticoagulation successfully interrupting this and improving mortality and morbidity. And then we'll discuss the somewhat more mundane topic of preventing the overt venous thromboembolism that we may see in these populations and how to manage it. So let's look back to H1N1. We seem to have a keen interest in doing so. So at a single institution, for example, they noted that in the first surge, food for thought people, in the first surge, they used prophylaxis, enoxaparin twice a day or unfractionated heparin 3 times a day. And even with that prophylaxis, noted there was a 23-fold increase in risk of PE compared to the non-H1N1 ARDS. And so in the second surge, again, food for thought people, they elected to give everyone IV therapeutic anticoagulation. And sure enough, that aggressive approach resulted in a much lower risk of venous thromboembolism. There was bleeding, but they asserted not worse than they had with prophylaxis, but included fatal intracranial hemorrhage in those on ECMO. But there was no difference in the mortality. Move forward to an article Dr. Bull alluded to already, looking at consecutive ICU pneumonia patients in Wuhan, China. 22% received prophylactic anticoagulation. There was no difference in mortality unless you were in the subset that was COVID positive and had a D dimer greater than 6-fold the upper limit of normal. So I think before we leap to the conclusion that we can tell who needs anticoagulation, never mind who is destined to have high mortality, I'd point out that there were higher D dimers in the non-COVID pneumonia patients, and they did not benefit by mortality analysis with heparin. So I think we need to disconnect the notion about D dimer perhaps being a marker of anything, although I think it conveys severity and mortality perhaps, but it certainly doesn't seem to link to anticoagulation. And then in New York, where amazing studies come out with thousands of patients in 1 month's time in a given healthcare system, they noted that 28% of individuals received systemic anticoagulation. Now, the other 70+% may have received prophylactic anticoagulation or no anticoagulation, but the comparator was those who received systemic anticoagulation. Those individuals were more likely to require ventilatory support. My interpretation is they were really sick, and the reason for initiation of anticoagulation was not provided. But at the end of the day, the mortality was 22% whether or not you got anticoagulation, although you lived a week longer if you received anticoagulation, except for the subset. So in a subset of individuals who were required intubation and received systemic anticoagulation, their mortality was lower at the price of doubling the risk of major bleeding, which was reported to be 3%. So I think in aggregate, we have a sense that there may be subsets that may benefit from anticoagulation. Or do I mean heparin? So let me point out that heparin, in fact, is anti-inflammatory, blocks complement, may protect endothelium, and there's some data that suggests it's antiviral. So we've heard elegantly about multiple processes in play, and while I don't discount that inhibiting thrombosis is good, it's what I do for a living, we must be clear and further understand going forward. And our friend Dr. Hippensteel shows up again with a review that's just been accepted for publication about the so-called off-target effects of heparin. Nonetheless, we know that COVID-19 patients are susceptible to thrombosis, and why wouldn't they be? This is the list of factors that we know predict for benefit from inpatient prophylaxis against VTE, and you can check the box on many COVID patients for every single one of these risk factors. You've heard Dr. Bull talk about the risk in the critically ill, but how about just the acutely ill hospitalized patients? Data are much harder to come by, And there are 3 studies without correlation to the use or absence of prophylactic anticoagulation, but the estimates vary from as low as less than 1% to as high as 10% of having arterial events. And there was, again, a large cohort from New York hospital system. In 1 month's time, they had 3,500 patients admitted, and the risk of ischemic stroke was 0.9% in 32 of these patients. Now, these are people in their 60s with diabetes, hypertension, other risk factors, but their conclusion was this was higher than they would have expected. I think we do need to take care, however, if we start wandering away from the hospital. There are no data for those who are never hospitalized with their COVID-19 or those who appear to have asymptomatic infection with this virus. I would argue that the mediator of this thrombosis has to do with the very severe illness and the processes that take place in it. And if you're home and well or asymptomatic, I don't think we should presume that they're present. We need to be aware of the antidotes and relative risks. So of that New York cohort where 32 had strokes, only 7 of them were not ill with their COVID-19, which gives you a risk of 0.001%, not 1%. And we know that even in other viral situations, including seasonal flus, that there's an increased risk of childhood stroke with these various viral infections, but the absolute risk is arguably relatively small. And so we might hear about things, the media tells us about things and all the badness that COVID can do, but that may or may not apply to the general population. We may simply be revealing the risk of those who are vulnerable to this virus or the next virus or some other stressor. And then finally, beware coincidences in the era of doing testing, driving by the Pepsi Center, getting your nose swabbed. Just because there's a virus on the end of that tip does not mean if you are otherwise well, that caused your femoral vein to clot. Heck, maybe it was the wait in line at the Pepsi Center. But I think we have to be careful about drawing conclusions and associations in this early stage in the absence of data. On the other hand, a couple of months ago when I spent time on the consult service and as a hematologist, we were being asked to develop strategies as we saw this rumbling herd of potentially prothrombotic patients coming in. And it was a very interesting time where belief and experience outweighed, in some cases, looking at the facts or looking at facts as melding my personal view, I was plenty guilty as charged, or my experience in what we should do. And so what we found is that across the UC Health system, there were various practices that ranged from giving everyone IV heparin, as they did in that single institution study in H1N1, to agreeing maybe prophylaxis is needed, but gosh, they could bleed. And we sought to develop consensus. And so we could agree on some basic concepts in the management and prevention of VTE. We agreed that these patients were sick when they were hospitalized. They meet criteria for thromboprophylaxis. There was also a cohort of us that were concerned about once daily enoxaparin as the standard prophylaxis. Enoxaparin has a half-life of 8 to 12 hours, which cuts it in most populations, but in treatment trials, it was demonstrated to be less effective in people who were obese or had cancer. And so is this population different enough than the general medical population that once daily enoxaparin may not last? There was concern. There's always concern about fixed dosing in obese patients. And although more prominent with unfractionated heparin, heparins can bind to inflammatory proteins. That's why they're anti-inflammatory, and thus they aren't around to serve as an anticoagulant. We knew there was a target anti-10A for the rare circumstances in which we monitor prophylaxis, that is 0.2 to 0.5 units per mil, and so we sought to see what was happening. And so in early April, the services, including ICU services, were very gracious to allow us to do some anti-10A levels on individuals receiving prophylaxis. And what you can see in a significant part of the cohort, we could not detect heparin activity, for what that's worth, in a subset of patients receiving enoxaparin once a day. And in another subset, we could detect it, but only at mid-interval, not at trough. And the discerning difference was, I'm sorry to say, a D-dimer. And you could only find detectable heparin in these very small samples if the D-dimer was less than 3,000, a number that resonated with the Wuhan data we discussed earlier. And on the other hand, if there was markers of tissue death and injury, like a high ferritin, that's when the heparin detectability disappeared, in contrast to a couple of folks who were receiving enoxaparin twice a day where levels were detectable. So incorporating this and the concepts, we agreed that perhaps enoxaparin once a day isn't the best in persons who may have some more severe illness, and also in data not shown, perhaps in very obese patients. Twice daily seemed to be doing better in a couple of folks. D-dimer was what we had to hang our hat on a couple of months ago, not for clotability, but for mortality and severity and discerning who had heparin levels and who didn't. And so we devised the guidelines that many of you in the clinical field may have seen. So if you had a D-dimer less than 1500 or a thromboelastograph, which is what our colleagues used in some of the surge ICU units, that indicated things were going okay, you got standard prophylaxis, but newly as a recommended practice to adjust for weight. And if the D-dimer was greater than 1500, then we used twice daily dosing at somewhat higher doses. These doses we did not make up. They were taken and borrowed from other populations, trauma, bariatric surgery, other situations where people were concerned enough to intensify anticoagulation beyond the once daily recommendation. Now you might say, Dr. Hassell, you said 3,000 and this says 1,500. This represents the effort across a diverse system full of very smart people who are very passionate about their beliefs, that there was concern that if we made the cutoff 3,000, that this would be insufficient to capture the people most at risk. Other data were found about 1,500 being a cutoff for a D-dimer that may be hazardous, and consensus was born. We then got asked about what to do when people were being discharged. And we reasoned that if all you received was the standard prophylaxis, so almost always floor patients, and you didn't, other than adjusting for weight, we just did the usual, that you were probably okay on the outpatient setting. On the other end of the spectrum, if you required therapeutic anticoagulation because you came in on it, or you developed new atrial fibrillation, you had a new documented thrombosis, or highly clinically suspected, that you should go home on therapeutic anticoagulation and for at least 3 months. We were cautious, recommend caution about the use of direct oral anticoagulants. They aren't monitored. Extremes of weight may be problematic as they're at fixed dose, and shifting renal function may create concern. And there's no evidence that we could find that treating arterial thrombotic events with anticoagulants should be done differently than from the non-COVID population. But that left a significant cohort of individuals who did receive intensification, either through the recommendations or for those practitioners who continue to give IV heparin. And so we reasoned that they would be people who would perhaps continue to be at risk when they went to rehab or when they were discharged. We recognize there were other factors, including cancer patients, pregnant patients with high comorbidities, or by the things that are on the score that is used to, in other populations, decide whether or not post-hospitalization prophylaxis is warranted. We recommended the use of Petrixaban. I know you can't spell it. It is available on formulary, but hard to come by and probably very expensive. It actually has the best data as regards efficacy and safety for post-hospital prophylaxis. Enoxaparin and Rivaroxaban, however, were mostly non-inferior in studies that did not do direct comparisons across these. The bleeding risk is somewhat higher, but these are available agents, and we recommended to consider this in that group where we were worried enough about you inpatient to, quote, intensify, such that we should continue to have concerns about the lingering effects of this very profound infection. And we were feeling pretty good about that. We look forward to collaborating with colleagues to look at outcomes data, not just heparin levels, to see if this matters both in terms of benefit and harm. And then the ACCP came out with its guidance last week. And so the ACCP is an entity that in thrombosis we look to. They sit, they ruminate over data, and they issue very detailed guidelines. They looked at the same data and more that we looked at. They didn't believe it, and they recommend business as usual. So they acknowledge that there may be failure of standard prophylaxis, but the data are scarce and not rigorous. They recommend thromboprophylaxis for inpatients, whether in the unit or on the floor, and to treat VTE as usual. One could consider extended prophylaxis, but they were not enthusiastic. And I must say this is congruent with every other society's recommendation. The International International Society of Thrombosis and Hemostasis, American Society of Hematology, the Journal of the Association of Cardiologists, you name it, the British Society of Hematology. Despite what we thought we had done thoughtfully and based on reasoning with local input, no one seems to be endorsing that on a programmatic or an organizational level. So where does this leave us for the next surge? Because we all think it's coming. So I think, in summary of what you've heard today, we are eagerly awaiting the strong work of our basic science colleagues to continue to generate the data that give us information about the potential clinical interventions. Perhaps if we block complement, correct hypoxia, and reduce inflammation or apoptosis, we won't need anticoagulants to impact the course of the disease, or maybe we won't get away with really modifying this disease without also controlling the thrombosis. We need guidance from the scientists who are discerning the mechanisms. There are more than 60 trials in clinicaltrials.gov looking at anticoagulation for various purposes in COVID-19. So we're hopeful that these data will help clarify the risks and benefits of anticoagulation for both disease modification and for appropriate approaches for prevention and treatment of venous thromboembolism. But what if the surge is next week? Now that Memorial Day is done, there's been a lot of civil unrest, and the herd is out. And so I would submit that we've learned a good lesson about working across disciplines, across departments, and setting aside our beliefs and experiences, or at least thoughtfully integrating them, and allowing facts as we have them come to us, to allow the facts to shape our theories rather than maneuvering the bits of data that we have to feed our own notions. And I think it's been a very interesting time. I would add thanks to every single person perhaps listening, whether you've been involved in the clinical care or the research. It was a very amazing experience to see people come together around this seemingly simple little issue. And I particularly acknowledge my colleague, Dr. Toby Trujillo, who would really help to bring people together to get some guidance on what to do until we have better data. And with that, I will turn it back over to Dr. Schwartz.
Okay, thanks very much. This has been a great series of talks, all focused on the endothelium and the injury of the endothelium. So let me start with a fundamental question. Todd, you brought up the issue of silent hypoxemia. Could you explain that a little bit more? Why would someone not become short of breath when they're hypoxemic?
Well, yeah, and so this is sort of more of a observation as opposed to to give you a great explanation for it. This is a scenario we see in shunt physiology not at all infrequently. I mean, when I said that, I usually allude to this in my pulmonary hypertension clinic. When I see patients with longstanding ASDs, VSDs who sort of march through their day with O2 sats that we can't really bring above the mid 80s. But blue lips, blue fingernails, but don't respond to this hypoxia in a way with hypercapnia, aren't actually seeking oxygen. We frequently have to remind them to do so. And so more of a, again, an observation from that standpoint. I don't know, again, if I can give you a good physiologic explanation for it as opposed to an observation, but pretty well established as a shunt, sort of a shunt phenotype, if you will, which is why, when this was sort of popping up, is this what we were seeing, this shunt-like physiology, is this what we were seeing before? Different again, because a lot of people were like, well, this is then HAPE-like. HAPE patients very much experience their hypoxemia. They know this is not shunt physiology from their standpoint. It's lung water physiology. The analogy became this dysregulation of the pulmonary vascular bed, which is what's seen in HAPE as well, sort of an inappropriate shunting of blood to specific areas of the lung, then leak is the thought to be the physiology. So sort of not perhaps not a most satisfying from an explanation standpoint, more of an observation. So.
Eric, did you have some other thoughts?
I mean, I think it's fascinating, really. I mean, as I said before, the virus never ends to astound. I think there's increasing interest also in how the virus might directly impact the brain and also affect the brain's ability to sense the hypoxia. I agree with Dr. Bohl that that if you're doing just plain old shunt, you're not engaging stretch receptors and getting a sensation of impaired compliance. But just like we're starting to appreciate that the loss of smell and taste may be actually direct brain injury, I believe there's been work done on the original SARS, also has a direct neurotoxic effect. It's possible also you may be shaping the way the brain senses the environment, including the sensation of dyspnea. That's something that I know several investigators are working on right now. So
teach us a little bit more about hypoxia. How hypoxemic does the pulmonary vasculature have to become for the endothelium to be damaged? When does the endothelium suffer hypoxemic insult?
Well, by itself, I mean, the lung obviously is a very aerated organ, and you need a pretty profound injury for oxygen not to be able to diffuse there. My mentor, Ruben Tudor, has shown there's a pretty wide radius by which oxygen can get throughout the lung and just via diffusion. That being said, you can get pretty profoundly hypoxemic, particularly if you have neutrophils in there gobbling up oxygen. And so I don't know if there's a specific threshold, and I think it probably is context dependent. Dr. Stenmark is a world's expert in HIF signaling, so he may be able to know that better than me. But just because the lung is bathed in air, it doesn't mean you're not going to get pockets of intense hypoxemia, in part because you have very active cells gobbling up and exhausting the oxygen there. So I don't know if Kurt, you want to add anything to that?
Yeah, not too much. I think the question is a good one, and the way we're thinking about it, at least, is that it's context dependent now in terms of the injury. So hypoxia alone looks like it can induce a whole series of events, and you can get the pulmonary edema that Dr. Schmidt talked about. But we put animals, including mice, in severely hypoxemic conditions, and they don't develop a lot of distress, but they actually do activate complement, and they do initiate a series of events that leads to pulmonary hypertension. And so now the question comes up that we're studying and are interested in is, so the patients that seem to be at greatest risk for this disease are those patients with underlying diseases that are associated with vascular inflammation, so diabetes, atherosclerosis, all of those. And so we find very interesting responses in cells that we get from the diseased circulation compared to the normal circulation in terms of how they respond to hypoxia or hypoxia plus, certain kinds of cytokines. And so I think that, again, there's no direct answer to the question yet, but those are the kinds of studies that we propose to do. We'll see whether or not we get funding for them with Tim Morrison and others at looking at various combinations of different, not only normal cells, but cells from patients that seem to be the most affected. And so, yeah, I think those will be fascinating studies, as I think Dr. Fauci was pointing out yesterday. I think we've seen so many different and unique things that he says this virus is the most distinct that he's ever seen, much more complicated than HIV. So now the time really starts for doing some very basic science studies that Dr. Hassell, mentioned, and trying to understand, all the factors that might be going into the inflammation, the thrombosis, the frank vascular endothelial injury, because it's more complicated than simply activating complement and a little bit of hypoxia. So I don't know. Hopefully in the next year or two, we'll figure it out.
So, Kurt, in your presentation, you threw us a little bit of a curveball. We thought you were going to talk about HIF-1 alpha stabilization, inflammation, and tissue injury. What's the role of that mechanism in the response to COVID, in the infection of COVID lung?
Well, so the HIFs, I mean, there's HIF-1 and there's HIF-2, and so, as other people have shown, I think, one of my colleagues, Christine Vowinkle, has demonstrated, Sean Colgan, that, activation of HIF-1 and acute lung injury is important in the resolution of the disease. So, we don't really have many questions about that. What we're interested in is, as I showed, is that when we knocked out HIF-1 through a variety of techniques, genetic and or pharmacologic, and exposed animals to hypoxia, that, contrary to what most people believed would happen, it didn't have any effects. But when we specifically knock out HIF2 on the endothelium alone, make the animals hypoxic, we don't get any disease. So there's seems to be, our hypothesis in COVID is that it would be the abnormal signaling through HIF2 that activates complement, that then activates inflammation and thrombosis, and that synergizes again with the disease process. And so one has to be careful, I think, about, lumping all the HIFs into one category and thinking that, attacking one is going to be beneficial, or, enhancing another will always work. And so there will be different circumstances that one has to consider when talking about HIF signaling.
Okay. So given the beneficial effects of unfractionated heparin in terms of its antiviral and anti-inflammatory effects, its so-called off-target effects, why not use it in this disease? What's the trade-off?
Well, go ahead, Derek.
No, please, Dr. Hassell, please.
I'm going to answer in a very mundane and simplistic way because this was discussed. Firstly, I think, and we'll hear what Eric has to say about data that need yet to be revealed and discovered about, is this real enough a phenomenon to make it an important consideration? Because I can tell you on a very practical clinical level, part of why the ACCP recommends once daily enoxaparin and part of why people shy away from unfractionated heparin is flat out, you have to send the staff in 2 or 3 times a day for injections. And that is viewed as an perhaps unjustified and unnecessary risk of exposure of staff for purposes of prophylaxis. And that, at the end of the day, it came down to a very practical decision in that regard. But I think we're going to hear a much more elegant response from Eric about, is that worth it? Is there enough theoretical difference to seek to use unfractionated heparin?
Well, yeah, I mean, I definitely defer to Dr. Hassell's expertise on this for sure. And we've talked about this in the days leading up to this. Heparin, this is what my lab studies is, heparin and heparan sulfate. And we just, as we mentioned, Joe Hippensteel, this is the Joe Hippensteel Hour of Power. We've mentioned him multiple times. He just published a review article 2 days ago talking about the theoretic benefits and risks of heparin. I feel like initially when the COVID-19 pandemic started, we were much more worried about going in the room. I feel like now we with adequate PPE and more expertise, I feel like that's become less of a problem, although obviously we want to make sure that anything we do to our patient has the potential to benefit regardless of the patient's isolation status. The heparin itself is, as you mentioned, the longer the heparin strand is, the more tightly it binds to the spike protein on SARS-CoV-2. Low molecular weight heparins tend not to bind. So enoxaparin had much less binding than plain old unfractionated heparin. And there's been increasing studies that, at least in vitro, if you give heparin, you can block infectiousness of these viro cells, which are not epithelial cells. They're just these cells that people use to test infectivity. So there is a theoretic benefit of unfractionated heparin. But Todd and I gave this grand rounds or a pro-con debate several weeks ago. And the thing I always bring up is that just because it could have a benefit doesn't mean that it does have a benefit. Coagulation itself, it's a very complex process. And every other study of heparin and other critical illnesses, lung injury, has not translated into a mortality benefit. So I think it's full of promise, but it demands randomized controlled studies to understand it. Every failed randomized controlled study began with an agent that was full of promise. And so I feel like that's where we are right now. It's full of promise, and we just need to see where these studies are going. So I applaud these randomized controlled studies, not only on preventing clotting, but also on preventing the expansion of lung injury during COVID-19.
If I could tag onto that really quickly, because I think part of what we're talking about here is this microvascular changes in the so what we saw in the Prowse and the Scarlet study without benefit from that standpoint. But really, again, this what appears to be this high incidence prevalence of VTE. I think definitely catches one's eye. And so, could we identify the biomarker or the surrogate biomarker or something to that effect that points us in a way about who to anticoagulate, weighing that clotting, bleeding risk. One thing I mentioned in our debate was that as someone who, and Dr. Hassell as well, deals with clotting all the time, I much prefer bleeding to clotting. I have to say, clotting is a bear once it gets going. So trying to figure this out. But as Eric tied on, these are the studies, and as Kathy said, when I looked right before this, 72 trials right now in trials.gov looking at thrombosis and COVID-19. So hopefully some answers forthcoming from that standpoint.
And this is Kathy. I'm just going to add one tag on, and that is, why are we relying on a messy drug that's given IV that needs a PTT to block complement or to block inflammation, right? I mean, okay, so we have this other problem, as Todd just alluded to, not insignificant of VTE, and we're going to do it anyway. But it seems to me the answer in this disease and in the modern era is to block complement, is to reduce viral infection. Why would we give heparin to stop a virus? How about giving an antiviral? Easy to say, but at the end of the day, this might be a stopgap measure to use a drug that has multiple benefits, including preventing VTE. I'm a hematologist. I love heparin. But at the end of the day, if what we're trying to do is block complement, trying to reduce inflammation, cell death, et cetera, we should target that. And my drugs might not be the best choice in controlling the disease.
So we do have a question about blocking complement. What's the role of eculizumab, a monoclonal against C5, complement C5, in COVID-related disease? Kurt, you probably have an opinion on this.
Yeah, unfortunately, I always have opinions. It's not based on too many facts. So I think there is a clinical trial, as I tried to mention, for at least 3 complement inhibitors: eculizumab, which is a C5 inhibitor, AMI-101, which is a C3, which is a little bit upstream of the C5, and then there are antibodies against the C5a. Just starting with the C5a, because that was the first trial that I saw that came out, just the first 2 patients that were treated with antibodies against C5a during their hypoxemic phase, they had dramatic increases in oxygenation, which is what sort of Todd's looking for, and what we're interested in. So the eculizumab, is a very expensive drug, but it would block, the ability of C5 to then, go to the anaphylotoxin C5a. You wouldn't get the terminal MAC complex, and so there's every reason to believe. I know what I know about complement, as I said, mostly from Dr. Hollers and Dr. Thurman, but just what I know, Dr. Hollers would suggest that eculizumab in certain patients at the right time could be a very good drug for all the reasons that Kathy Hassell said. And so we actually are studying that, at least in vitro, and trying to block the interactions of the CoV-2 with hypoxia by blocking C5 or C3, and then seeing if we can stop, at least in vitro, platelet aggregation and activation of macrophages. So time will tell, but I believe that there is a good reason that if I were a patient with this disease, I would prefer to get eculizumab versus heparin early stages of the disease.
Mm-hmm. Okay. So this is a question that's directed to Todd Bull, but I'm sure everyone else will have an opinion about this. In addition to the high IQ of the pulmonary endothelium, what are the unique features of the pulmonary endothelium that make it more vulnerable?
Make it more vulnerable, I guess, to this virus in particular.
Is it just proximity to the infection?
Oh, I see. I see what you're getting at. So certainly it does express ACE2, but as all endothelium does, it's, after the epithelial aspect of it, then the endothelium is one of the higher expressors of ACE2. It's, if this is a respiratory virus, then sort of your illusion that this is its entry point into the epithelium with then rapid access to the pulmonary endothelium would certainly raise the question. And then I guess what would have kicked around this would be hypothesis generating: is this hypoxia important? Of course, then that would raise the question, because the lung is impacted, you get the leak, you get local hypoxia, and is that playing a role? Again, that's, I think, Kurt's hypothesis there, and certainly needs to be worked out. Of course, you could caveat back, okay, why not the renal endothelium? But in terms of having hypoxia as well. But we also, this is being contemplated certainly in other vascular beds as well. That Lancet paper that Kurt listed also showed renal endothelium with evidence of infection. Certainly there's been much description or discussion regarding the renal failure that is ensuing in this patients. We were running low on dialysis CVH machines there for a period of time. So I don't know that. I don't know that it's just the pulmonary endothelium that's taking a beating here. The stroke risk as well. So I guess that would be my stab at it.
Any other thoughts? Let me ask a related question. How does the risk of chronic vascular disease or the presence of chronic vascular disease affect the pulmonary endothelium? And in particular, are individuals with pulmonary vascular disease at higher risk? Why are individuals with diabetes at higher risk? Is the pulmonary endothelium affected by diabetes or systemic hypertension? We know those individuals are at increased risk.
I can tell you, if I can just say on the clinical side of pulmonary hypertension, that's actually something I was really interested in, especially when we started discussing this shunt-like physiology, because all the drugs that we add for pulmonary vasodilators, in theory, well, not just in theory, in practice, will worsen a shunt physiology if you have infiltrate. So we don't add our pulmonary vasodilators if you have pulmonary edema, for left heart dysfunction, because you'll get hypoxemic. When our patients get pneumonia, they tend to do worse just in pulmonary hypertension. But here's what's kind of fascinating, and again, now we have to tease this out, is so when I first saw this, one of my patients entered the COVID ICU when I was working there. So she was on triple oral therapy, so 3 different oral pulmonary artery vasodilators. We had intubated 90% plus of patients who had come into the COVID ICU at that point. And our patients, many know, don't do well when they go on the ventilator. And so I was quite concerned about her and was sort of gearing up. And she was one of the few patients, at least in the week that I was on, who came into the unit. Her oxygen kind of rose, and then, we opted to not stop her pulmonary vasodilators because her RV didn't look great. And then she turned right around and left the unit, looked fine. Scratched my head. So then I called around to my friends across the country, trying to find out how many of their patients had entered the ICU. And essentially, we only could find none here at this point that hit the ICU. Now, is that because we train our patients to be very careful in social distancing, and they take social distancing to a whole new level? Certainly, that is a possibility. But there was a case report by Rohan Zamanian at Stanford, they have a big PH center, where he had a patient who went positive, who was on triple oral therapy, developed COVID-19, refused to come into the hospital. So he arranged for her to get inhaled nitric oxide as an outpatient. He wrote this up and published it in the Blue Journal, and she did well, which, I'm not quite sure what to make of that, other than it's sort of an interesting observation. So that is, I think, we have a database now, the FAR database, which is many of the big centers in the country enter their patients into this, trying to extract this information now to see what's happening to our PH patients, and more hypotheses than answers. But
also, just something else to add to the complexity and confusion of this. So weirdly enough, in patients with just non-COVID ARDS, diabetes is actually protective. This sounds crazy, but if you have, this was described as a score to predict your progression to ARDS from other illnesses, and the only comorbidity that actually decreased your score was diabetes, which kind of raises is that true? Could that be true? But there's other things like that, the obesity paradox, that obese patients are less likely to get cardiogenic pulmonary edema, and in some situations, non-cardiogenic pulmonary edema. So again, it just shows how complex this is, and how it just, we're searching for simple answers. But again, something is quite unique about, I do believe something is unique about this, based on the fact that we see almost always that diabetes and hypertension are highly associated with worse outcomes in COVID-19. It doesn't hold true necessarily for the broad ARDS category as a whole.
Just to add one more point to the conundrum that Todd's raised, is that I'm surprised. I've called my friends around the world, like Todd, to try and figure out what's going on. And Dave Badish would say the same thing that Todd said. These patients are so careful that maybe they're just not getting exposed the same way. We're writing a couple papers right now showing that, trying to explain, why the aging population, why the populations with severe or significant, we'll say, systemic inflammation are different than people who don't have that. So we have cells from, the chronic PH patient versus the control patients, and even from really young patients. At an epigenetic level, the genes that are involved in inflammation are remarkably altered in the setting of chronic inflammation, such that they have an open chromatin structure, and their promoter regions, their enhancer regions are wide open, and they're binding a variety of transcription factors, including pioneering transcription factors, which keep the chromatin open. So now any little stimulus, at least in ex vivo culture systems, can drive the system completely crazy, and it doesn't happen in a control cell in the same way. And so, ultimately we're trying to figure out, how and why, particular patient populations and why their cells are behaving in certain ways in response to, an inflammatory stress. And we have some clues, but whether or not that translates into, the broad clinical observations that are being made clear here, we don't really know. I mean, I say there's a lot of work still to be done.
What about the expression of ACE2 receptors? What is it like? What is the expression of ACE2 receptors like across the vascular bed in the lung? Is it increased in areas where you see the most endothelialitis? And how is the expression of ACE2 receptors affected by disease, chronic diseases, especially pulmonary vascular diseases?
Well, if somebody knows the answer, I'd like to hear it. I don't know. Number two, I mean, it's easy to say that there's lots of ACE2 expression on endothelial cells. That's been a little bit more difficult to, actually demonstrate. So in one of the studies that Oliver Eichelberg talked about that was published in Cell, if you do single cell sequencing analysis of the entire lung and all the organs in the body, and then do quantitative analysis, actually, one of the people in my lab, reanalyzed all that data. Compared to the epithelial cells, compared to macrophages, compared to lymphocytes, the endothelium has very, very little ACE2 expression. And then the real question can come up as to what happens during the infection. Does it actually increase ACE2 expression in other endothelial cells, or in the cell that's infected? It's possible, it looks like there's data that suggests the ACE2 expression goes down, which then leads to imbalances in angiotensin 2 and angiotensin, 1 through 7. So I think it's premature to really try to say that there's a longitudinal gradient of ACE2 expression in endothelial cells. Do large vessels, express the same amount of small vessels? At least based on the data that I see, the most up-to-date single cell sequencing data, it's not clear yet.
So let me end with a question that I think is perplexing to all of us, which is some of the individuals we would think are most susceptible to disease, like those with autoimmune diseases or those on anti-inflammatory agents, don't appear to be overrepresented in the individuals that are hospitalized and that are those that suffer the most consequences of COVID infection. What's going on? Why isn't the inflammation? Why does this appear to have such a minimal effect in terms of the infectious process? Is there something inherent about the virus as opposed to the host affecting this interaction between the virus and the endothelium?
Oh, well, I think I guess the short answer is we still just don't know. I think I can be pretty secure in saying that. It's interesting because it's, the first interpretation you can say is, well, geez, these patients, well, actually back when Italy was hit hard, there was an observation that patients with inflammatory bowel disease never died from this. There was actually a publication that they had profound protection. And the thought was, is there something about chronic inflammation, or maybe these patients were on immunosuppressives? And I feel like anecdotally, although as Dr. Hassell said, it's a very dangerous thing to say, anecdotally, it's a striking lack of patients who are immunosuppressed. Or purposely immunosuppressed, let me put it that way.
Striking lack of transplant patients.
Yeah, exactly. Now the temptation, and I think the temptation is to say, well, look, we're blocking the cytokine storm. And I would caution against that interpretation, because multiple studies, just like the D-dimer story, have shown that, for example, IL-6 levels, which we target in COVID-19, is less than sepsis, significantly less than sepsis, which has failed in anti-IL-6 therapies. There's a preprint out there, again, a preprint caution, but from Stanford, where they just did a screening of 60 or so inflammatory cytokines in COVID-19. And again, if it's anything, it's equal or less than sepsis or ARDS. So I feel like we're tempted to ascribe the protective effects of immunosuppressants on suppressing the cytokine storm, yet I don't think we have clear evidence that this is an accentuated cytokine storm. We see high ferritin, we don't really quite know what is a ferritin in regular ARDS. So I think it's interesting, but I think there's a risk in, at least I struggle with wanting to explain everything by my observation, and things don't 100% match up.
Any other thoughts? Okay, well, I want to thank all of the speakers. Excellent job. You've made it clear that this is an incredibly complex area that really is in need of additional investigation. And I think will provide insights way beyond coronavirus. So thanks very much. Appreciate everything you put into this.
Thank you.
Thanks for the invitation.
Thanks, everybody.
Thank you.